Good morning, everyone. My name is Oliver, the AP Fellow at Service Hospital. Today, I would like to extend the ECG for discussion. This is some of this ECG.
Is the that part.
Okay, good.
Very effort. I think the complexities are regular, and the RR interval is about 2.5 boxes. So I think the rate is about 120, and so it is tachycardia. And when you see the QRS complex in lead 1 and lead AVF, lead 1 positive and AVF may be neutral. So I think it is normal axis with lateral left axis deviation. And V1 is negative and V6 is positive. So the transition is in the V3 to V4. And when you see the rhythm strip, I think the P wave and QRS is associated one by one, but the P wave is quite big and it is negative in lead 2. And I cannot discriminate the P wave well in the lead 1, but lead 2 is negative. So, and the lead A wave is also negative. So I think this P wave is not coming from the sinus node. And considering the tachycardia, I think it could be the AT, maybe coming near from the AV node side. So it goes up to the SA node side. And there's no significant ST elevation or Q wave in this ECG.
Mm-hmm.
I agree with you. And you see the narrow QRS with the tachycardia with the T wave conversion. I also think the AT with the AV origin or the about near origin. Okay.
It's 80. EGM, could you please localize the regional side?
When we see the P wave morphology, lead 1 and ABL is positive, so coming from the right, the 2-3 ABF is negative, so it is the lower part. When we see the prepodial lead, we want to positive and V3 to 6 is negative. I inferior. I'm not sure.
So,
Okay. I agree.
Agree about what?
Mine is
right.
The left.
Left side. Left side. Left side.
Left side.
Participant.
People.
Participant.
This one's left side.
No, left. Yeah, third one.
Third one.
Participant, are you there? We need your change point. Let's see.
So where is the this P wave is coming from? The first thing, where you think it's coming from? Right atrium or left atrium?
P1 T wave is positive, that means it comes left ventral.
Left lateral
Side.
is a lead 3 is a negative, right? P wave. And then lead 2 is most negative, right? And then after that, AVF and lead 3. So negative lead 3 mean what? Left or right?
Means comes down to up. Maybe.
Well, it is most likely left side, the posterior lateral or posterior septal area, because your precordial transition, P wave, V2, V3, and then if you look at the negativity, grow gradually up to B4 is a deepest negativity, B4, B5, and B6 become a little bit less negative. Okay? So is it fair to say that if you look at your 12-lead ECG precorder, remember, and in order to be 2, 3F negative, and then left lateral become negative, so the left side, posterior lateral. Okay? So this, everybody agree this is a ectopic atrial tachycardia? Is that what you guys thinking? So how do we interpret this QRS duration now? What's the QRS looks like? Patient has a right bundle branch block morphology, right? Correct? V1, V2. Okay, RSR prime. So I think it is a more right bundle pattern because if you look at the R wave progression, B6, even though it's R, but it's smaller than B5 and B4, right? Amplitude-wise. So this QRS activation sequence is normal or is abnormal?
I think it's not normal.
Okay. So how do you differentiate this with a patient who has, let's say, rotation of the heart versus underlying conduction abnormality? Can this caused by the rotation of the heart, or this is anatomically defective ventricular orientation? That's what I'm asking. So lead 1 is positive QRS duration, right? QRS rate positive. AVL is positive, right? So QRS axis is rotated to the what? Leftward superiorly, correct? And AVR is negative, right? So this is just simply could be a sort of a conduction abnormality due to the, let's say, left anterior fascicular block, for example, or because in the presence of a bundle branch block, incomplete. Maybe patient has associated conduction abnormality in the ventricle. That may also explain why you got deep S wave in V6, V5, and V4. That's not normal to have a deep S wave of V4, V5, V6, right? So this ventricle is not activating also normally, abnormal. So summarizing, you got a P wave morphology coming from the looks like a left side, probably posterolateral area, and then you have QRS has underlying right bundle, incomplete right bundle morphology with left to superior axis. Okay? Anything else do you want to talk about here? So differential diagnosis is what? You guys are all ectopic atrial tachycardia? What's the differential diagnosis? Besides ectopic aortic tachycardia, what kind of tachycardia can do this type of P wave, deep P wave precordially? And then also 2-3 AVF negative. They can have a long RP tachycardia, even though ectopic aortic tachycardia can be possibly be other differential diagnosis like persistent reciprocally junctional tachycardia, PJRT. Rate would be slow, okay? But a PJRT alone would not do this. Probably has to be underlying conduction abnormality together. So when you see patient have such a slow tachycardia with a persistent, and the differential diagnosis need to be expanded. Obviously, ectopic tachycardia, long RP tachycardia. The other one would be left-sided posterolateral PJRT, persistent junctional reciprocal tachycardia. That's the Vienton tachycardia that involve your conduction system, slow pathway, often or nodal conduction. So that's what it causes this type of tachycardia, slow, persistent tachycardia. Anything else we need to say? Any other differential diagnosis? No? Can you have a nodal ventricular axillary pathway like this? Nodal ventricular axillary pathway, left-sided one? Even though it's possible, but then usually they are shorter RP tachycardia than this, just very long RP tachycardia. Okay? So differential diagnosis. Anything else? You can think about it. Anybody has any other comment?
Yeah, the conference.
If there's no other comment, let's look at the clinical history.
Okay.
Okay?
Patient is 30 years old. Moment
Uh-huh.
presented with palpitation. The palpitation was
Uh-huh.
2 weeks ago.
Mhm.
Lasted more than 2 hours. Onset was
Okay. Mm-hmm.
speed up to 120 beats per minute. And
Mm-hmm.
the time actual tachycardia diagnosis, also
Okay.
the SBC diagnosis. She was started in the north since in June 2025.
Mm-hmm.
The patient's test results, chest X-ray was unremarkable,
Okay.
and pre-RFA echo showed normal left ventricular ejection fraction of 66%. Also, during the TT showed dilated coronary sinus,
Mm-hmm.
raising suspicion of persistent left SBC, and agitated saline contrast study confirmed the diagnosis of persistent left SVC. And
Okay.
also we checked persistent left SVC during the EP study.
Mm-hmm. Okay.
And the last EP finding was the originating from CS osteo. So
Wait a minute now. Hang on a second there. How do you define the CS ostium in persistent left superior vena cava patient?
mm,
Did you do angiogram?
yeah,
Did you
yeah, it was 2025.
person angiogram?
Yes.
Okay.
Did they did angiogram?
Yes. So how easy to identify the also the persistent superior vena cava ostium? My question is,
Was difficult.
persistent superior vena cava is very much a dilated coronary sinus, and then they almost looks like a horseshoe if you're looking at the right atrium and the persistent superior vena cava. So definition of a persistent superior vena cava can be very difficult. Ostium definition. So how do we define angiographically? That's what I'm asking you. Oh, this is something that you're going to do again, again, again in your career. So in the aerial view, if you're able to see MCV, middle cardiac vein, posteriorly coming straight down. I don't see it, but I think maybe that stump that you see small, maybe that's a MCV. In the left side of the picture, if you look at the something still pointing down, yeah, that one, that might be the MCV. That need to look at the projection in the LAO view, and that would be close as you can get definition of a radiographically persistent supravenous cava MCV. Okay? Sometimes supravenous cava is so big that very hard to feel, but if you do good contact injection, you can see that. I can see your, true cardiac, anterior cardiac vein. I mean, great cardiac vein on the arterial view also. There's something sticking out. Yeah, that's a great cardiac vein. And the other one is a persistent supravenous cava. Okay? So sometimes arterial view is more useful, but I'm not quite convinced that stump is still the MCV or not. Okay? All right. So you use intracardiac echo, looks like, or TE. What did you use? Did you use intracardiac echo to look at this, or just angiographically you did that?
Angiography.
Angiography. Okay. All right. Go ahead.
The reason I choose this ECG is that I tried several ECG algorithms to localize
Uh-huh.
the atrial tachycardia,
Yes.
but none of them gave me a confident answer. This case taught me that thinking about the three-dimensional electro anatomy and the direction of activation can be more helpful for relying on algorithm alone. So this is the patient's post-ablation ECG.
So that's after the ablation?
Mhm.
Okay.
What's that?
So what do you see?
I can see the sinus rhythm, heartbeat about 125, 60, and normal axis deviation, and P wave late 2 is small, and late 3 VFP waves small, also biphasic. And also, if we can see the carefully, the V2, V3, P wave also a little bit notching, and intellectual activation delay slightly.
So what is the characteristic, morphological sort of a characteristic of a persistent supravenous cava? First of all, how many different type of supravenous cava do you know? Just one supravenous cava, left side, persistent left supravenous cava? So usually we like to, if you will, discuss about three different kind of persistent supravenous cava. One is that there's only one supravenous cava that is a persistent left side supravenous cava without right side normal supravenous cava. That is all the upper extremity drain into that abnormal supravenous cava. Okay? It's called type 1. Type 2, you can have A and B. Type A is that you have two supravenous cava, one in the right, one in the left. But there is a communication between two. So inanimate vein is present. Okay? There's type B is they are separate off. There's no connection between two. So left arm drain to the left side, right arm drain to the normal IVC, SBC I mean. Okay? And then finally, there's a last one is that you only have what we call distal form. That is persistent supravenous cava only connect to the left atrium, not to the right side. Okay? Now, in occasion when patient have a congenital heart disease, supravenous cava roof to the left atrium does not close up. Then you have a venous ASD. Basically, supravenous cava left side, left atrium floor is one single hole. Okay? That's probably one of the cases you saw in Mongolia, a young lady. So there's many variations that exist. So when you see patient has persistent supravenous cava, you need to obviously analyze morphologically very carefully. This patient had a CAT scan by any chance?
No.
No. So you don't know what type of she has, whether she has only one communication vein from the upper extremity to the heart, or there's a two separate SBC. The reason I'm asking you that question is, if you have a type 1, you don't have a normal right side supravena cava, probably patient develops sick-sinus syndrome at a very young age. The reason is presence of right supravena cava is a primordial tissue, importance of genesis of a normal formation sinus node. Absence of that supravena cava, congenital formation sinus nodes get deranged, sometimes absent. Then patient will present like a junctional rhythm. Okay? So this is a clinical implication you need to know. And obviously, treating pacemaker, things like that, is also important. Okay? So it would be good to have when you see patient or person supravena cava, unless you have really good imaging or good idea what anatomic structure it is, your job is to document it. Since you're the first doctor to diagnose this, for the posteriority patient needs some medical service, something like that, they already know what her problem is. Okay? It's an important first step. Second, obviously, you're trying to make a diagnosis of a top palpitation and tachycardia, so on. So typically, persistent left suprarenal cava known to have what? Atrial tachycardia like this. What else? Atrial fibrillation, focal arrhythmia, reentry. It's a very important causes of persistent atrial fibrillation in these people. Okay? Because of many of these supravena cava, posterolateral conjunction of the left atrium, they are connected to musculature. So they basically involve the left superior pulmonary vein, inferior pulmonary vein, carina, anterior carina, appendage muscle, attach it all together. It's very difficult to isolate. Lastly, importance of this case is that the patient fortunately has only ectopic atrial tachycardia. That does not mean this patient is going to be remaining like this. Patient may develop in the future focal atrial tachycardia further distal to the vein, even atrial fibrillation. Lastly, if you guys are going to do transseptal catheterization in these people, left atrium is very smaller than normal because of persistent supravenular presence. Basically, don't let the left atrium develop full dimension. So transseptal may be a little challenging. What we learn in this type of patient, when you have often tachycardia, the AV nRT is the most common. Second is obviously ectopic atrial tachycardia, but ectopic atrial tachycardia often comes from junction between left atrial posterolateral wall, posteroseptal wall, and the roof of a persistent left respiratory canal. So where did you ablate this patient? Do you know ablation site?
She is Austrian.
Awesome, where? Is it roof or anterior posterior?
Oh,
Awesome is a big. This is almost like another chamber here. Okay, so this doesn't do any help us. So you don't want to look at it. Make sure that where you ablate it. You don't want to ablate roof of a persistent left supravenular cava because these people AV nodes sit there. They're going to cause a heart block. So for the EP guys, first thing you should know when you deal with the persistent supravenular cava, the anatomic definition of an AV node first and his bundle. You have to mark that very carefully because it's very difficult to find slow petty potentials, things like that in this type of patient. So anatomically it can be very challenging. Okay? Good case. Any other concern question? Or lastly, why patient had right bundle branch block? Is it rate-dependent aberrancy?
the sinus.
Initially, no. Tachycardia EKG. You see? B2. Look at the B2 ECG. Now look at the sinus rhythm. Okay, go back to sinus. What other change you see?
I think maybe the rate dependence.
Yes, QRS also normalized pretty much, right? Normal right bundle branch block. Okay. So could it be this patient may have some conduction abnormality? And you also notice that the V3, P wave duration, second component notched. That's a left atrial P wave, very small. Okay. So those are typically what we see in this type of patient. But a P wave axis also, this patient is not complete normal. right? Because the negative lead 3 still. The sinus node location a little bit perhaps lower than anticipate you like to see. Okay? It's not the completely normal axis P wave though, because the lead 2 is almost biphasic or flat biphasic, right? So that doesn't fit the definition of sinus rhythm. Because 3 is negative, 2 is flat, lead 1 is positive. Okay? So this patient may have a sinus node abnormality as well. We don't know. Time will tell us. You did not do sinus node recovery time, anything like that. So then you will never know the answer. Okay? All right. So it's important, again, you guys do good EP study to step-by approach when you're learning to sinus node functions and things like that, all this, especially congenital heart disease, when it's thinking they may be sinus node involved in this process. Okay. Any other question for us, please?
Any other questions? No. No. Thank you very much.
Okay, thank you.
Thank you.
Is in the conference. Today I will introduce the PSVT case. 62 years old female patients came in emergency department our hospital with narrow complex tachycardia. Actually, she came first time in March of 2026. Her symptoms started several years ago. From last year, almost several times feel palpitation a day. The tachycardia refractory to medical therapy. When she came at first emergency, she was diagnosed acute hepatitis C. So in that time, we just stopped tachycardia and the other tachycardia treatment postponed until the acute hepatitis completely treated. Then she came again in our emergency due to palpitation in May. In that time, we just planned to do ablation therapy. She was diagnosed with hypertension several years ago. In that time, she took the antihypertensive drug. When we performed the transthoracic echocardiography, she had the mild hypertrophy left ventricular wall. The ejection fraction was normal. This ECG documented during the normal sinus rhythm. In here, just I just can see the left axis deviation. Otherwise, the ECG was normal during sinus rhythm. I can't see any pre-excitation or any other conduction abnormalities here. When she arrived at first time, she brought this tachycardia ECG. In here, initially I thought maybe it short RP tachycardia because I could see the retrograde P waves just after the QRS complex. But we did the ECG again in our emergency. In this ECG, it looks blurred, but in V1 lead, we can see the retrograde P waves, but P waves in between the R waves. So the documented nerve complex tachycardia with mid-RP. Also, we performed the 24 hours Holter monitoring. During the Holter monitoring, several episodes of tachycardia documented. Tachycardia easily induced the single APC and the sustained. It means the easily inducibility suggests the tachycardia mechanism is more likely the reentry, and also the entrance that exits length is long. suggest a large excitable gap. It means maybe due to the accessory pathway or the AV node reentrant tachycardia. And here we also can see the EPC-induced slow mid-RP tachycardia. So in that time, I'm a little bit confused. It is actually the PSVT, the other forms of tachycardia. And then we planned the patient catheter ablation in May. We used the duodecapolar catheter for coronary sinus and the quadrupolar catheter RV, the another one in HES, and we started the EP study. When we start the procedure, the patient had the sinus rhythm, cycle length 820, PR and QRS interval, QT was normal. While we were trying to place the catheters, the tachycardia already started. So we started just evaluated the tachycardia. When we see the tachycardia, the atrial activation was eccentric. The earliest atrial activation was in CS distal. CS12 is the earliest section, earliest site of the tachycardia. Also, atrial activation in between the V activation. So it maybe the long RP, mid RP tachycardia due to decremental maybe LV conduction. And usually when we diagnose the left side accessory pathway, it's conduction usually short, but in time the VA conduction was longer than usual accessory pathway. Then we try to do the differential diagnosis. During the tachycardia, we perform the reset. When we reset the contralateral side, because the tachycardia location in the left side, we paste from the right side, so it's so contralateral. So we couldn't reveal the no significant change in the VA because the RV resulted in LV CS12 conduction due to the decremental conduction. We showed the red row, the decremental conduction. After termination tachycardia, we paced from the ventricle. RV pacing 400. We revealed the eccentric VA Winkelbach and also the decremental conduction by the accessory pathway. Yellow arrow showed the decremental conduction, and the red arrow showed the Winkelbach in this picture. Then we try to reset a reset from IRA. When we do the A reset, we can see the A fusion over the AVRT. When we can see the A fusion during the atrial stimulation. It helps us to exclude the EV and RT. Usually it's during the AVRT. And the longer AV conduction due to also the slow pathway conduction with echo, followed by the longer VA conduction AVRT. And we the A reset from high RA, the longer AV conduction, then echo, then the longer VA conduction. Then we try to reset the ipsilateral side. This one is coronary sinus distal, 400. We pace 400, and we can advance the subsequent fee 3019 from the 2030. It means it helps us to exclude the AVNRT, because when the pacing site is close to the bypass tract, it quickly more rapidly advance the B site. Also, then we try to RV stimulation the more earlier. So the more earlier RV pacing can advance the next A. We can see this differentiation in coronary sinus lead. Also, we're trying to do the AV reset, but during the AV reset, we couldn't catch left atrium, so we can't evaluate the AV reset result. Then we're trying to do entrainment, re-entrainment during the tachycardia. When we perform the re-entrainment, here the Winkelbach after after second beat, we can see the Winkelbach and termination tachycardia, then the tachycardia reinitiation. When we're trying to ventricular entrainment during the tachycardia terminated, or the VA Winkelbach occurred, so we can evaluate the entrainment result also. After termination tachycardia, we try to induce tachycardia. Tachycardia really easily induced the atrial X-ray stimulus, also the right atrial pacing. When we pace coronary sinus 1-2 IVRT induction was occurred without the jump. Also, from the right atrial pacing, tachycardia induced. So during the EP study, we concluded that the tachycardia, during the tachycardia, atrial activation was eccentric. It means it helps us to exclude the EVNRT, because during the EVNRT, atrial activation usually concentric. If it is eccentric with the left extension, but the usually atrial activation site, the proximal coronary sinus, or the near the coronary os. Then the atrial activation sequence during the pacing, similar to during the supraventricular tachycardia, that helps us to diagnose the orthodromic AVRT or EVNRT, but it can help us to exclude the AT. Also, the early S2 stimulation from right ventricular advanced the next coronary sinus. It favors for AVRT. Also, the ipsilateral pacing advanced the subsequent V favor AVRT. During the AVNRT, it should be no effect. Also, during the RV pacing, when we usually observe the VA interval is constant, if the accessory pathway rapidly conduction, In that time, in that case, we just observed the VA decremental conduction. It means maybe the accessory pathway with decremental conduction. So we diagnosed this is left lateral accessory pathway with the decremental conduction, and we start to mapping and ablation during the RVPC. We used flex irrigation catheter, and when we start the ablation, more the ventricular side, and during the ablation, from the LV PVC revealed the bypass tract signal. It showed the red row and the picture. After few ablation times, the atrial activation sequence was concentric, and also then we observed the accessory pathway potential here. So we ablated. We performed the booster ablation. After ablation, we used isoprenaline and tried to induce tachycardia. During the pacing, coronary sinus 5-6, 300, AV block cycling occurred. EST 500 to 150, AV nodal effective refractory period occurred. We didn't observe the AH jump during the EST. Also, we did the VSD after the ablation, the VSD 450 and 360 VA conduction effective refractory period occurred. So we finished the cases, and thank you for your attention. And if you any comments and questions.
Oh, a nice presentation, Dr. Nat. Good morning. My name is Taeyeon Hwang from Yonsei University, and usually our modulator Daehoon Kim is in Japan due to the TTS. So I will introduce today's panel, El Sue A from Myanmar.
Yes, thank you. I'm Le Sui E from Myanmar. Yes, thank you.
Oh, sorry.
Yes, yeah, it's okay. It's okay. Yes, and nice to meet you all. I'm from Myanmar, and I will be the moderator for the today presentation by Dr. Anand. And thank you very much, Dr. Anand, for your very much interesting case of the paroxysmal supraventricular tachycardia. We do have so many cases of supraventricular tachycardia in our daily clinical practice, and it is usually, not very simple in the EP study to have a correct diagnosis in the EP lab. So I like the way you presented before. You look at the ECG very well so that you can guess what the mechanism is. So you describe the RP period for the diagnosis of the SVT ECG, and then another one is the interesting the Holter monitoring. Yes, sometimes the patients can present with the palpitation, but they might not have a proper ECG recording, especially for the patients from the very remote region or who are not very much accessible to the ECG service. And then we might ask them to do the Holter monitoring, and if they have some episodes of tachycardia during the Holter monitoring, we can guess the mechanism of tachycardia from the 24-hour Holter monitoring. And this is very much useful tool for the diagnosis of the SVT as well. And in our clinical practice, we usually see the accessory pathway conductions from the right lateral or left lateral, but in my opinion, we we rarely see the decremental accessory pathway. Usually, we usually see the accessory pathway with conduction, but sometimes not always decremental. So it might be difficult for you to have the diagnosis in the EP lab, and you are doing the quite uh, many maneuvers to confirm the SVD as well, and this is very much interesting. So I'll open the floor for the discussion from the audience and from the EP specialist from the Yonsei lab and Professor Changwan as well. Thank you. Thank you for your presentation.
Anybody had any question? Anybody has any comment and question, please?
I enjoyed your presentation very well, but can you explain more about the when you do the V-pacing and the decremental VA? Can you show the EGM, please?
Oh,
Okay, there's a slide.
We can't see your slide.
Oh,
you just showed a second ago.
okay. Now, can you see my slide?
Yes,
Yeah.
we can see now.
Uh,
Can you explain this, the eccentric VA when kebab via decremental accessor pathway?
okay. When the accessory pathway with no decremental conduction, we can't see we just usually constant VA conduction when we pacing the ventricular side. If you have the decremental conduction accessory pathway, we can see when we piercing the right ventricular or other ventricular side, just the VA conduction times is lengthening, and it means the accessory pathway, the decremental conduction, like the normal conduction system. So in here, when we pace the right ventricular, first the VA conduction, then we just occurred the Wenkeberg. Then after that, the third beat, and the VA conduction is shorter than the a third bit conduction. So if we, how can I explain? If we have the normal accessory pathway usually don't have the decremental properties. So we can't see this lengthening of the conduction. So that means the conduction, VA conduction lengthening as VA conduction lengthening during the ventricular pacing. It means your accessory pathway most likely the decremental conduction.
That answer your question, Dr. Huang?
Okay, and
Okay.
yeah.
Let me just rephrase what Anand says. If you fix the cycle lengths of, let's say, in the scenario of 400 milliseconds, if you conduct VA conduction through the pathway conduction going to be everything or nothing. That means you can only have a 2-to-1 block. You cannot have Wenkiba, or conduct doesn't conduct. Okay? Second important thing is, when you pace a RV, you can have a certain delay steam to the capture. So you cannot count that as a decrement. So what you do, where is the earliest returning HR EGM, which is the CS distal here. So you have that catheter record the far field, the left ventricular potential. Can you see that? And then you measure that to the conducting A, you can see your yellow arrow becoming shorter, longer, blocked. You see that? Repeatedly. So this is basically the Wenckebach behavior of axillary pathway, not the nodal, because the his is late. Understood? Any question?
Yes, Dr. Huang, and good morning. It's me, Heng from Cambodia. So, also have one question for speaker. If it's really a pathway that have decremental conduction on the left side, so what do you think about? Is it just a normal accessory pathway, or it's a Mannheim like on the left side because of the decremental conduction? So when we pass from the
Well,
RV, and
first
we
of all,
have
yes. Hang on a second. Hang. When you ask a question, you need to think carefully. Mannheim pathway only conduct anterogradely, does not conduct retrogradely. Okay? So your question may be, is this like something like a PGRT or something like that? And which he conduct not pre-excited, but conduct only retrograde decrementally. Okay? It is, I don't know whether this is a PGRT type of a pathway or not. We have not proved any other evidence of that. And as you know, PGRT tachycardia can be slow like this. This is not unusual. I mean, that's very unusually slow tachycardia, even the left side pathway. Second is that it's a decremental. Now, do we have any concrete evidence that this is a PGRT type of tachycardia? We don't. Now, PGRT tachycardia is there decremental because they involve some degree of slow pathway. In this patient, post-ablation, did not have a jump, did not have a slow pathway conduction. So I don't know whether that would be a right answer, but I certainly 100% sure I cannot tell you. Okay?
okay.
Now, if you, Ananda, go forward, keep going, show us a slide. That's an important point, and I just want to make one quick point. Move forward, slide, keep going. No, backward. Now keep going forward. I'm going to numbers 18 or 19, I think. Okay, keep going. Yeah, right there. Hold on. This here. So during the tachycardia, you deliver atrial extra stimulus, right? That advanced the next A or not? Next B? Did, right? The
Yes.
B came prematurely.
Mm.
And then that generate retrograde conduction. My question to you, do you think this is another branch of pathway conduction, or this could be, slow pathway, reticular slow pathway conduction, or could it be reticular fast without concealed because of your prematurity? Only reason I ask that question is that your CS activation, earliest is CS56 or 3-4 area. So I wonder, is there a possibility of another sort of another pathway that exit to the more proximal to the CS? Normally that would prefer conduction to distal CS. That possibility we cannot exclude here. Okay? Maybe very first tachycardia, they diagnosed 12 ECG, you thought the patient had short RP tachycardia. Remember
Yes.
that? That
Yes.
timing is almost same as this. Okay?
Mm.
So based on clinical evidence, maybe perhaps this patient has a tachycardia with a single pathway, decremental conducting pathway, maybe different exits. That's quite possible. But I cannot prove that 100%, but I think that's what it is. So because of your post-ablation EP study, there was no dual venous physiology, no jump. Okay?
Okay.
Okay.
I also thought when I saw the patient in emergency, so short RP tachycardia, it's a clear the PV retrograde PV
Right.
just after the course complex.
Right.
So also the patient age and patient sex, maybe the I guess it looks like EBNRT, but
Right.
but in the emergency, the tachycardia also the other type. For this slide, I thought when we paste the high array, and then the fusion bit between the pace and the accessory pathway, because I thought the excitable gap is broad, so maybe the actual fusion. No, I just explained.
The reason is that, I know what you're trying to tell me, but if you look at septal A, his A, during the S2 from the A, changed, polarity changes. Do you see it? During the tachycardia, his proximal initial negative, when you're pacing S2 during the tachycardia became positive.
Yes.
Yeah, his A changed. So this is not a fusion. Okay?
Okay.
Okay. And then I think a question is whether this is an echo bit or this is through the slow pathway or maybe another different exit site of a pathway. I think argument is that since your single site ablation eliminate all tachycardia, this may be the pathway. Okay, keep going. Keep going. There's one more thing I want to point out. Go to the 19, toward the 19, please. 19. Forward, not backward. Forward. Yes, keep going. I just want to point to one thing quick. Keep going. So your one of the last slide when you're mapping. Keep going. Keep going. Okay, keep going. Yeah, right there. Hold on there. Okay. No, go back that slide, please. Just before. 24. 23. I think 23 the one. One more back. That's it. Yes, leave it here. So, no. 23. 2-3. Go forward one slide, please. Yes. No, not that one. Forward and then next one. That's it. Leave there, please. No. Yes. So, no. Number 23.
Here.
No.
This slide is
previous
23.
one. Yeah, that one. Yes. So leave there. Let's discuss about this. No, you keep moving.
I think there is a time delay.
Okay.
23.
Yes, good.
Yeah.
So this is your RV pacing and your mapping with ablation catheter. And then Ananda said that we move the catheter way down to the ventricle. Can you see that? In ablation, distal almost V, almost no A there. Therefore, I feel A. So when you guys see coronary sinus EGM, actually left-sided pathway, atrial signal is quite sharp and large, and you only see far field V, that means your CS is much more above anatomically compared to true mitral valve annulus way of thinking. Number two reason, if you see such a long BA conduction time, it's very hard to find the pathway potential. So here, something interesting happened. What happened? IV pacing, but the last bit, if you look at the no longer left bundle morphology, right bundle morphology, can you see that? That's a catheter-induced PVC, ablation catheter-induced PVC. Then your pathway potential became very much evident compared to the right ventricle pacing. Can you see that? So it is important when you guys have such a long VA conduction time, far field V, you don't know where the exactly location of axillary pathway. That's why I tell my fellow that please pace LV. Look at the reticular activation and the CS EGM, see if you can evidence of pathway potential. And this is one of the such example. Okay? So you can, instead of making your day very difficult, it's just a simple 30-second maneuvering, pacing LV before you decide to ablate the left side pathway. You can show you beautiful axillary pathway potential and you know exactly where it is, then you can just ablate it. Okay? You can see actually pathway potential on the ablation distal number second beat and third beat. That notching thing in the downstroke of the QRS is a pathway potential. But you want a more clear cut than pace the LD. That's what I can say. Okay? So I think it is not common to see left-sided decremental axillary pathway. And characteristic of decremental pathway, number one, tachycardia rate is slow. Like this patient, 150, 140s. Normal like left-sided pathway should be 180, 190, 200. So you get something wrong. Second thing is that they are usually, typically present with incessant type of symptoms because your accelerated gap is very long. So it is important to keep that in mind. That's why in children, when they develop PGRT, because of the incessant nature of tachycardia, they can develop tachycardia-induced cardiomyopathy very easily. But this patient has a normal ejection fraction and all that, so I don't see any trouble with that. Okay?
Okay.
Any other question, please? Any comment from anyone?
Yes, Dr. Huang.
Yes, sir.
How can we explain the decremental conductions of the left side SMC pathway? You said that maybe it's not PGLT. So, how can we explain that? I really confused.
Okay. There is many potential explanation for that. Question is PGRT been described in the left free wall, right side, and so on? Yes. Answer is yes. There's a PGRT case reported, published, many cases already, is more than outside of usual posterior septal pathway. Okay? This could be one of them, possible, but I have no proof of that. Second, clinical history of this patient is not consistent with the PGRT. Why? PGRT start young age, okay? Not typically 60. This is not usual clinical feature here. So if you want to characterize some arrhythmia, first important thing is to take a detailed history, when they started, how often it is, and so on, and how they start, when they try to increase the exercise, just start the tachycardia, and so on, okay? So that's epidemiologic finding. Number two important finding is that, if you had a PGRT, this patient probably would have been ablated a long time ago because it's very symptomatic, or she's been taking medication all the time. Now, what other explanation we have of decremental conducting pathway? I think I taught you, we discussed this before with you about this. If you look at the embryologic formation of AV canal, there is a primordial pacemaking type of cell, ring of a primordial ring, so-called we call primary ring, and the pathologists call. And often those only special tissue become sinus node, proximal bundle, and so on. And the remaining primordial tissue of a pacemaker type of cell, which has a connection 43 property, they disappear, become isolated. Some of them become basically completely isolated by surrounding fibroid tissue. They don't behave like ectopic atrial rhythm, but often, they can cause a PVC. They can also be source of a PAC. So, for example, you're ablating tricuspid annular PVC. We believe that probably reduces all primary ring pacemaking cell. Now, what happened in the scenario that when your axillary pathway has to be connecting, involving that residual primary ring nodal like a cell, you're going to have a documented conduction. That's a potential explanation that we can offer you. But do we have any proven pathologic cases or either histologic case that is a such thing exists? No. Only thing we know that there's a paper by Mark Maguire wrote he spent years in a Robert Anderson lab. He studied systematically tricuspid and mitral annulus ring, histologic cross-section human anatomy cadaver, find many AV nodal cell like distribution cells around there. So that is explanation. Okay? And that is such example is what you mentioned. Mahaim is possibly one, and then the other one is a PJRT and so on. So I think that's all we know. The question is that anybody ever published the concrete evidence that documented axillary pathway involving such as small cells? No, there's no data. Just basically pathologic-based speculation. That's I can offer you explanation.
Okay,
Anybody
thank you.
any other comment? Anybody has any other explanation, possibly why the axillary pathway can be documental? But axillary pathway, documental axillary pathway is not that common, very rare case. I think his case is wonderfully presented. I enjoyed this case when I did a case with her in Mongolia. So I think this is a proper case to present and then teach other people who come across a similar case. They know what to do now. Okay? A good educational case. Any other comment, please? I think Dr. Tay was trying to say something. I cannot hear her.
Sorry, yeah. I have one question in the chat box from the audience. In this type of tachycardia, is the ventricular overdrive pacing can be done with the entrainment because this is from the left-sided SSW pathway and VOB from the RV is possible?
What do you guys think? I can just give you an answer to that. If you're going to entrain during the tachycardia RV entrainment, okay, first of all, you have to synchronize very carefully local V, RV catheter in sense distal. Second, your entrainment rate cannot be much faster than slightly, maybe 20 milliseconds earlier than tachycardia. Otherwise, you're going to cause a Wenckebach block and terminate tachycardia. Okay? Exactly what happened in this case. It was very difficult to sustain entrainment from the RV. Okay? So perhaps if you had the opportunity to put a catheter under the CS distal where the axillary pathway conduction is, maybe entrainment there would maybe more synchronized, maybe you can do more effectively, prove that. Okay? But from the RV, you got a long distance away and a large excitable gap there. So you may have many things can happen, collision of wavefront, and then also preferential conduction and so on. So I don't know whether that is something feasible to do. But I think single S2 or S3 may do the job instead of overdrive pacing. Okay?
Okay, thank you.
Okay. I think if nobody has any question, Dr. Hong, take over.
Okay, thank you again, and congratulations to Dr. Inan. And the next meeting of the International Case Conference is on the August 29, and the presenter would be So Chan-mei from Myanmar, and also the panelist is in our South Korea. So thank you again, and enjoy your weekend.
Thank you so
Thank
much.
you. Thank you very
Yeah,
much.
very good.
Bye-bye.
Thank you.
Bye-bye.
Bye-bye.
Nice to see you all.
Thank you.
Thank you.